support they need during their fertility experience. Kia ora koutou, I'm Kate Barbie and I'm the Support Coordinator for Fertility New Zealand. Thank you for joining us tonight and welcome to Fertility New Zealand's webinar series and tonight's webinar, Navigating Fertility, the Role of Fertility Nurses. Fertility New Zealand walks alongside all people facing fertility challenges. We do this by providing support and information services and being the voice of our community through our advocacy work. I encourage you to jump onto our website and check out our services and connect with us on social media. Tonight, I'm so pleased to introduce to you Christine Martin, who is our wonderful guest presenter. Christine is the charge nurse at Fertility Plus in Auckland, and she's also a board advisor here at Fertility New Zealand. Tonight, Christine is going to cover what to expect at your first appointment and so much more. At the end, we'll have some time for questions. Pop them into the chat at any time, and we'll go through them with Christine after the presentation. Over to you, Christine.
Thank you so much for that introduction, and kia ora koutou, everybody. Thank you for spending your Tuesday. Sorry. Yeah, so as I was saying, I'm going to talk a little bit about public funding, talk about what to expect from your first appointment at a fertility clinic, some of the common reasons that people have challenges getting pregnant, some of the testing that you may be asked to do, and some of the treatment options. So 1 in 4 people, according to the World Health Organization, at some point in their life will suffer from infertility, which is defined as a disease of the male or female reproductive tract, and failure to achieve pregnancy after 12 months or more of regular trying. So eligibility for publicly funded appointment, women have to be under the age of 40 at the time of referral. So as long as the referral is in before they're 40, they're eligible. And for a man, it's under 55 years. Women need to have a BMI under 35 and men under 40. Both partners need to have a work permit, which is valid for 2 years, and have to have been trying to get pregnant for a year or have a known severe cause, so known problems with ovulation, no sperm or tubal factor, or a genetic condition that requires pre-genetic diagnostic testing. So any one of those things will make you eligible for a publicly funded first appointment. You're not eligible if you smoke or if you smoked within 3 months of the appointment, if you use drugs or abuse alcohol within 12 months, if you're in jail, if you have 2 or more children at home, included adopted children at any age to the same relationship, or 2 or more children from previous relationships living at home at least half of the time. When you come in for your first appointment, you'll be asked to do a follicle-stimulating hormone blood test and estrogen on day 2 of your cycle. At the beginning of your menstrual cycle, all of your hormones will be low. Your FSH, E2, progesterone, and your HCG, which is your pregnancy hormone, which will be negative. And that gives us some idea of where you're at as far as your how your ovaries are functioning. If there's a male partner, they'll be asked to do a semen analysis, and then the Northern Regional Funding Service will randomly allocate you to one of the 3 in Auckland, one of the 3 fertility clinics, and the rest of New Zealand it's Fertility Associates. When you come in for your first specialty appointment, they'll do, the specialist that you see will go through your history and may do an examination depending on what your history is. So for the lady coming in, they'll talk about the length of time that you've been trying to get pregnant, whether you've had any previous contraception, and how long you have not been taking contraception for, how often you have intercourse, and when you have intercourse, are you having it at the right time in your cycle, when you're most fertile. They'll talk about your menstrual cycles, whether they're irregular. They talk about previous pregnancies, any sexually transmitted infections. Go over your medical history, social history, family history, whether there's any problems, has been any problems in your family among female relatives with getting pregnant and conception, and any medications or allergies that you're on. If there's a male partner, they'll talk about any problems with erection or ejaculation, any previous paternities with other partners, and all of their medical surgical history, particularly if there's been ever been any injury or trauma to the testicles. If they do physical examination, generally it's just the height, weight, calculating BMI and blood pressure. If there's any signs of thyroid disease, they may have a feel of your neck to palpate for your thyroid gland. They may look at your skin for any secondary sexual characteristics like male pattern hair growth or acne in women, which may indicate PCOS. They may have a look at your tummy, do a vaginal exam, and for men, may do a testicular exam if indicated. There's really four main reasons that we look at that are usually responsible for problems with conception. The first one is problems or disorders with ovulation. That accounts for 25 to 35% of problems with conception. So we need you to release an egg every month, and an egg that could potentially create a viable pregnancy. The next one is disorders of the fallopian tube. If your tubes are blocked, the egg cannot travel down the tube into the uterus, so it's not going to fertilize. Then there's male factor infertility, so semen abnormalities, so low count, low motility, problems with the morphology, 2 heads, 2 tails, sometimes the DNA in the sperm can be an issue. And in 20 to 30% of cases, it's unexplained. Sometimes it's a combination of more than one thing. And actually that's the case in 30 to 40% of couples that have problems with conception. And these slides here, they're talking about percentages here. It doesn't take into consideration age related to infertility. It's not that's not represented here in those slides. This is just a diagram here of the testing that we do to see whether or not your tubes are blocked. So when you come in for your appointment with the doctor, they may, if you've never had your tubes tested and you haven't been getting pregnant, they will likely recommend that you have a hysterosalpingogram, which is a fancy way of saying putting a dye through your fallopian tubes to see whether or not they're open. So on that diagram on the left, you can see the purple going all the way down to the ovary, which indicates that that tube is open. It's a procedure that's just done up through the natural opening in the cervix, and a dye is injected through the tube. There's 2 different types of dye that can be used. One is water-based, it's called Omnipaque, and it's just diagnostic. And the other one is called Lipiodol, it's an oil-based dye. And there's a slightly therapeutic effect as well as diagnostic effect. So it's actually the type of dye that most specialists will recommend. It's got a lot of iodine in it, so the downside to it is that your thyroid function needs to be checked every month for 6 months after you've had the test, because you may need thyroid replacement after having the Lipiodol. But there's a good percentage of people after having the Lipiodol flushing of the tube that become pregnant naturally, which is why it's preferred over the water-based dye if there's no other risk factors. The next reason for that people may have problems with conception are disorders of ovulation. The most common one is polycystic ovarian syndrome, and that's the most prevalent cause for anovulation or not ovulating. There's also endocrine disorders, so problems with thyroid function. Ladies can have premature ovarian failure, meaning that their ovaries stop producing eggs, or as many eggs sooner than normal. So early depletion of ovarian follicles. Lifestyle can affect ovulation. If you've got a lot of stress, excessive weight or being underweight can affect lifestyle. Affect ovulation, and exercise can also affect ovulation. Excessive exercise, marathon runners, people that can affect your hormone balances and in turn affect ovulation. Certain medications, chemotherapy, hormones, and actually antipsychotics medication can also affect ovulation. The most common and easiest treatment for problems and disorders with ovulation is ovulation induction if you have PCOS, which is just an oral medication, either letrozole or Clomid, and it's taken for 5 days at the beginning of your cycle. If you're not regularly having a period, you may need a drug called Provera, which is a type of progesterone that you take for 7 days, and after you stop taking it, that will induce your menses, and after that you can start taking letrozole. Premature ovarian failure, you would do either intrauterine insemination, in vitro fertilization, or if you're really not ovulating, then there's the donor egg option. The testing to see whether or not you have disorders of ovulation are doing a luteal phase progesterone. So luteal phase is about a week after you ovulate. You can check the progesterone level. Progesterone only goes up when you ovulate. So if your progesterone levels are elevated a week after when we think you're going to ovulate, that indicates that ovulation has happened. So that's one of the tests they can possibly do to look at that. You can also do an ultrasound to look at the ovaries. That diagram on the right lower side of the screen is a polycystic looking ovary. So the ovary is quite large, and all those little round dark circles are all little follicles within the ovary, and they look kind of like a ring of pearls. So polycystic appearing ovaries can be diagnosed on ultrasound. It's usually diagnosed in combination with something else, so hormone testing of testosterone and androgens. There's higher male hormones in ladies with PCOS, and also like the male pattern, hair growth and acne are physical signs of PCOS as well, and obviously irregular periods. Premature ovarian failure, you can check anti-Müllerian hormone, which is a hormone that you can do at any time during the month, and it is an indicator of ovarian reserves, so how many available follicles you have left. So, a guideline for treating women with PCOS. Letrozole, which is one of the ovulation induction agents, is the first-line treatment, but it's not publicly funded. It's, as I was saying before, it's an oral medication that's taken for 5 days, and then you just have intercourse at your most fertile time between day 9 and about day 16 of your cycle. and hopefully become pregnant. Metformin can be used. You've probably heard of metformin being taken for type 2 diabetes. There's some studies that show that it can help with ovulation as well, but patients should understand that it's not as effective as other ovulation induction agents such as clomiphene or letrozole. Clomiphene can actually be used in combination with metformin. This next little graph is just a diagram of anti-Müllerian hormone, or AMH, which is that hormone that I was talking about that indicates what your ovarian reserve is, and it's based on your age. So as you can see, to the right-hand side of that graph, the older you get, the lower your ovarian reserve is. You're born with all the eggs you're ever going to have in your lifetime, and they age along with you, and they become less with every passing month. You have less eggs. So as you get older, your ovarian reserve also gets less. It's not an indicator of whether or not you'll become pregnant, because as long as you're ovulating and it's a good quality egg, you can become pregnant still. It's more an indication of, you know, how many available follicles you have in your ovaries. And we use that a lot when people are going through IVF, just so we have an indication of how much medication to give them. This diagram here just talks about IUI. So as far as fertility nurses' roles go, this is where they start kind of getting more involved in your care. So when you're actually in pre-treatment leading up to a treatment cycle, whether that's an IUI, intrauterine insemination, or IVF, that's when you'll start having a lot of contact with your IVF nurse. They'll go through all of your required testing, your sexually transmitted infection history, make sure your thyroid function's okay, your hemoglobin A1C is within normal limits, and make sure we've got a recent semen analysis. So they go through all of that testing. And then they also, those are the nurses are the people that you'll be calling with day one of your cycle, and they'll be walking you through that treatment. So the two medications that you can take are letrozole, that I was talking about before, which is also used for ovulation induction, and clomiphene. So clomiphene works a little bit differently. It triggers the brain's pituitary gland to secrete more follicle-stimulating hormone and more luteinizing hormone, which is the hormone that makes you ovulate. There is a higher risk of multiples, so clomiphene cannot be taken unmonitored. You have to come in at some point to the fertility clinic, at least on your first cycle, when we know how you're going to respond to the clomiphene, to have an ultrasound and see how many follicles are growing on the clomiphene, because you do not want to have an insemination when you have several follicles growing, because you might get pregnant with more than one baby. Letrozole can be safely used unmonitored because it doesn't have the same effect. It works differently. It's what's called an aromatase inhibitor, and it actually blocks the conversion of testosterone to estradiol. So those androgens that accumulate increase follicular sensitivity. So with letrozole, you can have an IUI cycle without actually having a scan safely, and that's why we can use it for ovulation induction outside of an IVF clinic. So just taking the letrozole yourself and having intercourse without being monitored, it's safe to take that way. The IUI cycle itself, you call with day one of your menstrual period. You'll talk to a nurse They'll tell you to take either clomiphene or letrozole from day 2 to 6 of your cycle, and then you'll start having blood tests to monitor your hormone levels. And when your hormone levels, when we've detected ovulation, you'll get a call. The male partner will come in and give a sperm specimen on the day that we call you to come in for the insemination, and then you'll have the insemination a couple of hours after the sperm sample has been given, so they can wash up the sperm in the lab, and so they've got a nice pure sample of sperm. Then the sperm is actually just with a speculum, like a speculum exam that you would have in the old days when smears. Now smears have kind of gone out of vogue a little bit with the new HPV testing, but when everybody had smears in the past, you had that speculum exam. So there'll be a speculum. The nurse will be doing that. They clean off the cervix and put a little fine flexible catheter through the opening, the natural opening in the cervix, up into the uterus, and then inject that sperm that's been prepared by the lab directly into the uterus. It takes only a couple of minutes to do, and then you can get up and go about your business. The pregnancy test is a couple of weeks after the insemination. They usually have you do a blood test a week later just to monitor your progesterone levels as well. This slide is a little out of order, sorry about that. So this is talking about seminal abnormalities. So before your appointment, coming in with the doctor, we do ask for a fertility semen analysis. And we like people to abstain from ejaculation for 2 to 3 days beforehand, and have the specimen looked at between 30 and 60 minutes after it's been collected. If it gets to the lab too late, the motility can be less, so it might not be quite so accurate. And a normal volume is greater than 1.4 mils. Greater than 16 million a mil is a good number, or greater than 39 million total sperm. If the sperm count is a bit low, or the motility is poor, they may recommend some lifestyle changes, more antioxidants, not getting so hot around the groin area. They may recommend IVF with a process called ICSI, which is when each sperm is injected directly into the eggs. So the diagram on the top is a natural insemination. It's an egg on the right with all the sperm trying to get into the zona of the egg. The diagram on the bottom is a picture of one single sperm being injected directly into the egg, and that would normally happen when there was a low count or motility, and that's that process called ICSI, or intracytoplasmic sperm injection. The other option would be donor sperm if a man was truly azoospermic. So there's another option for men that have azoospermia, and that is to surgically remove the sperm from the testicle. And that's done under local anaesthetic. It can be done with sedation if requested. And the sperm, a little bit of testicular tissue is taken out. The sperm is extracted from that. They're usually immotile because they're in shock, but they're frozen at that point. And then when they thaw it, that's when they really know whether or not they're viable. So testicular sperm extraction would be done if somebody had an ejaculatory dysfunction. If somebody had a vasectomy and there's that blockage, that's another reason why we might do it. so erectile dysfunction, azoospermia, or what's called retrograde ejaculation, when men ejaculate into the bladder. The IVF nurses would also be involved in that process. They would meet with the man and explain the procedure to him, and then they come to the fertility centre and get changed and go through the consent process, get prepared, have an IV put in, have their procedure, and then recover afterwards in the recovery room for an hour to two after the procedure. So it is done on site at the fertility centre. Some of the other tests that you may be asked to do is the pelvic ultrasound. So ultrasounds of the pelvis can look at the size and structure and shape of the uterus, to see whether there's a septum in the uterus, any polyps or fibroids or adhesions in the uterus as well, to see if there's something going on there. You always would have to have an ultrasound done before you have that tubal testing that I was talking about earlier. Hormone tests for polycystic ovarian syndrome, premature ovarian failure. They can look at your prolactin levels, testosterone levels, TSH, your thyroid stimulating hormone can affect your fertility as well. Hysteroscopy, if they do see some polyps or fibroids or adhesions on the ultrasound. Hysteroscopy, hystero means uteroscopy, looking into the uterus. So they just use a fine, flexible, small scope with a light on it. It's fibre optic, and it goes through the natural opening again into the uterus. And you can have a look on the inside of the uterus with a camera, monitor next to the bed, and see exactly what's going on there. There's a hystoscope that's quite narrow, and it's got like an operating field, so it is rigid, and they can actually remove polyps or fibroids or adhesions if they're small enough at the same time, and do a little DNC to clean out that dilatation and curettage, to clean out the inside of the uterus if they feel like that would be helpful. The AMH that I was talking about is not funded. It costs about $85 to have that done, but that's a helpful test for us if you are going through IVF, to give us an idea of how much medication you might need. You will always be asked to do prenatal blood tests, so we're looking for rubella immunity. We want to make sure that you do have immunity to rubella before starting treatment. And if there's any infectious diseases, those blood tests need to be current within a year of having treatment, because we don't want any infectious material in the lab. We look at your hemoglobin A1C, which is an indicator of diabetes, just to see whether you're at risk for gestational diabetes. And then we look at blood types. The SCSA, which is a sperm chromosome structural assay, that's an additional test to the fertility semen analysis, and it assesses the integrity of the sperm DNA, so see if there's any fragmentation in the sperm, which may be contributing to infertility. And then the other test is a procedure and a diagnostic test, is a laparoscopy. So if the transvaginal ultrasound is abnormal, they may look at doing a laparoscopy. A laparoscopy, you can sometimes see endometriosis on hysteroscopy, and sometimes also on ultrasound if it's deep and you have endometriomas. But laparoscopy is really kind of the gold standard way of looking for endometriosis as well, and that can be cleaned up at the same time as having the laparoscopy. So that might be another procedure that could be ordered if the specialist feels that it would be helpful. This is public funding for treatment. So there's a difference. So there's a public funding requirements for eligibility for your first appointment, and then there's different requirements for treatment. The main difference is that the BMI for women now goes from 35 for an appointment to 32 for treatment. For men, from 45 for an appointment to 40 for treatment. You're scored there's a scoring system called a CPAC, and it looks at whether or not you have children at home, how long you've been trying to get pregnant, what the causes are for your infertility, has there been previous sterilisation, and you need to get greater than 65 points on that CPAC form in order to be eligible for publicly funded treatment. And you can have up to 2 packages of care on with that public funding if you are eligible. Once you become eligible, at most fertility clinics, the waiting list is still about 14 months. So some people actually elect to have private treatment while they're waiting for their publicly funded treatment. The other area that you'll have a lot to do with the fertility nurses is if you are going through IVF. So if IVF, in vitro fertilization, is a recommended course of treatment, you will be calling the nurses the month before you want to start treatment to arrange a time to come in to be shown how to give yourself injections. Injections are generally taken for about 10 to 12 days. Everybody responds a little bit differently to the injections, but there's different types of cycles that use different types of medication in different doses, depending on what the fertility issue is. If you're doing, the most common cycle is called an antagonist cycle, and you start a follicle stimulating hormone on day 2 or 3 of your cycle, day 1 being the first day of your period. So after you've come in and had your injection teaching lesson with the nurses, they'll tell you to call the office or the clinic on day 1 of your cycle and instruct you what to do. And you'll have a lot to do with them from that point on. You'll be having pretty frequent blood tests coming in for 2, 3, sometimes 4 ultrasounds. And then they'll give you a call with your final trigger instructions, after which you'll have an egg retrieval 35 to 36 hours after your final injection. The final injection is what matures up, there's a final maturation process for the eggs. We don't want you to ovulate on your own. We want to get the eggs from your ovaries. So that diagram on the left is a picture of a vaginal ultrasound probe. On the side of it is a little needle that just goes through the very top part of the vaginal wall, right into the ovary, and to the far left of that, it's cut off a little bit, but the needle goes into the follicle within the ovary. The fluid is aspirated out of that follicle into a test tube. There's an embryologist in the room with you at the time of the egg retrieval, and they'll empty the follicular fluid into a petri dish and look at it under the microscope and can tell you before you leave the clinic that day how many eggs you got. Over the next couple of hours, they clean up the eggs. They take all the cumulus cells off the outside of the eggs, and they'll inseminate them, so put the sperm with the eggs, either by putting a drop of sperm directly on top of the egg or by injecting an individual sperm by the process of ICSI into the egg. The eggs and sperm then get left in the incubator overnight, and they'll give you a call the next day and tell you how many of those eggs fertilized. But the nurses are your main point of contact from the time you decide decide that you're going to move forward, or the time your public funding comes due for IVF, and starts really the month before the month that you're going to start treatment, with all the injection teaching instructions. So the most common cycle is the antagonist cycle, and that's a medication called FSH. Your body naturally makes enough FSH on its own to really supply one of those available antral follicles, but not more than that. So normally when you ovulate naturally, you ovulate one egg, sometimes two, which is how you end up with twins. But because we're giving you additional FSH, the aim is to grow all of the available follicles within the ovary, and get more than that, so we have more eggs that are available to fertilize. They're freezing a lot of embryos now. It's becoming more and more common. The rates of success with frozen and fresh embryo transfers are the same, but sometimes it's safer to freeze embryos if your body becomes too hyped up on the hormones, and they think that it may be safer to freeze embryos, wait for a month or two, and then you'd call back in for another day one for your embryo transfer. And this is a picture of an embryo transfer. So on the left-hand side of the screen, that big dark area is your bladder. You would come in with a full bladder for your embryo transfer. Your uterus is that kind of circular area below the dark area, and the white line is a picture of a catheter that has gone up through the cervix and is going up to the fundus of the uterus. The little white dot at the very top is a little air pocket, and that's when the embryo has been expelled. So embryos are microscopic, so you're not looking at the embryo, but there's a little bit of air that's loaded in the catheter behind the embryo, and when you see that little flash of light, that embryo has landed in the uterus, right in the nice spot in the trilaminar area of the uterus, which is a nice part of the lining. An embryo transfer is very similar to an IUI in that it's just a fine, thin, flexible catheter that is inserted through a speculum directly into the uterus. It's just that there's an embryo in the catheter and not sperm. The embryologist will bring the embryo in at the last minute, already loaded in the catheter, so it's ready to go and it's not outside for too long. Embryo transfers can be fresh or frozen, so you may have it 3 to 5 days after your eggs are collected, or if it's frozen, it could be 1, 2 months out. It could be 3, 4, 5 years out. Embryos are quite happy being frozen in the lab. We just need a consent to thaw them before the embryologist can thaw them and put them back. If you're having a frozen transfer, you can either have what's called a manufactured cycle or a natural cycle. So if you have regular periods, you likely will have a natural cycle. You'll call the nurses again on day one, and they'll check to make sure all of your required testing is up to date, and then they'll start monitoring you with blood tests to see when you ovulate, and then time your embryo transfer based on that, so mimicking what would happen on a natural cycle. A manufactured cycle, you're given estrogen, and we control when we want to put the embryo back, and then we start adding progesterone for the uterine lining after the embryo has gone back in. So those are the two different ways that that embryo transfers work. Most people say the most uncomfortable thing about an embryo transfer is the full bladder, because the purpose of the full bladder, it's done under ultrasound, but it's a transabdominal ultrasound. It's not a vaginal ultrasound, so the probe goes over the tummy. and the bladder actually pushes on the uterus to straighten out the angle of the uterus to make it easier to push the catheter, and it also gives the specialist an acoustical window, so it's much easier to see where you're going, and it's easier to push it because the angle's straighter, so it actually makes the embryo transfer easier to do. And it takes about 5 minutes to do. You can get up and go home afterwards. You can go to work if you would like to. We don't really like you to get too hot or do any heavy lifting or straining or anything like that after an embryo transfer. But for the most part, you can go for a walk, you can go back to work, you can do what you would normally do. And then you'll have blood tests after the embryo transfer as well. They'll be checking your progesterone level, and they may supplement more progesterone, which is normally a vaginal application of progesterone. And then you'll have your pregnancy test 9 days after a day 5 transfer. The nurses will also monitor you if you do become pregnant. They'll monitor your HCG, which is the pregnancy hormone, up until you are 6 weeks, 5 days or more pregnant, at which time they'll do your first ultrasound pregnancy scan. And if that's all good, then you'll be just discharged to your licensed maternity carer. The final little slide view is just a little bit about what happens in the lab. It's a little bit busy, but to the far left is the stimulation therapy. So that's cut off a little bit too, but it's actually a pre-filled syringe. That's a dial-up syringe, which is how the medication is injected. And then the next one is the egg retrieval. So there's the needle that goes up into the ovary, and those eggs are being suctioned into the test tube, which is where the next one is the petri dish, where they're looking at the eggs under the microscope. They prepare the sperm and they fertilize the egg, and then the embryos develop. So there's 5 different stages of development there. There's the first division, second division. Day 3, there's 6 to 8 cells. And on day 5, the embryonic and placental tissue is actually starting to separate out. So they're fairly robust embryos by day 5. We do a lot of day 5 and day 6 embryo transfers now. And that last picture is just the little thin flexible catheter that goes straight up into the uterus for the embryo transfer. And that's the nurse will be with you for all of your scans. They'll be with you, walking you through all of your blood tests, showing you how to give your medications. They'll be with you for the egg retrieval. If there's a sperm extraction, they'll be with you for that. They do the intrauterine inseminations, and they're basically your point of contact anytime that you're in cycle, so you're actually in treatment, is really the function of fertility nurses. So that's my final slide. Thank you very much for joining me tonight. If anybody's got any questions, I'd be happy to take them.
So, thank you for presenting and sharing that information with us. I thought while we wait for a couple of questions to come through, I have jotted down a few of my own. So that male patients can get their sperm tested through their GP and also in the lab with a clinic. What's the difference in getting it tested between the two different places?
Yeah, so if you're having your sperm tested with lab tests or what's now Awanui Lab, the difference is that most of the time people are collecting the specimen at home and bringing it in, and the time for them to test it is a lot longer sometimes. So it's not as accurate because we don't know how long it's been sitting in the lab before it actually gets tested. The count's going to be the same, but the motility might not be. And also the other thing that they can do in the lab is that extra DNA fragmentation testing if they want to do that. They don't do that in a regular just facilities semen analysis at lab tests or Awanui labs. But the big difference is that the storage and transport and time to testing is much more accurate within an IVF lab.
Awesome, thank you. And I saw your slide before about medications and your first appointment with your specialist and bits and pieces along those lines. What happens if somebody is on medication but not comfortable telling their doctor or their nurse that they could potentially be on like an antidepressant or an anxiety medication? Is it possible to have IVF treatment or fertility treatment being on those types of medications?
So there's some like antidepressants that are safe during pregnancy. So some of the SSIs, the serotonin uptake inhibitor medications, are safe during pregnancy, but there are a lot that are not. It would actually be dangerous. So it's always a good idea to tell your specialist exactly what you're on, because there's some medications that you definitely cannot take if you're pregnant. There's some, I mean, it's very difficult to test medications on pregnant women, so it would be pretty unethical, which is why, some of the new line diabetic drugs, they don't recommend that you take them during pregnancy. The only things that you can really take are metformin and insulin, because they've been around forever and they've been safely taken in pregnancies, so they're pretty confident that they're okay. But there's a lot of like the antipsychotic drugs, for example, that are unsafe. The other thing too is if you're going to, especially if you're going through a hospital, when you look up a patient online, you can see their dispensing history. So you probably could figure it out anyway. For the most part, we know what people are taking from their history.
Yeah. Oh, that's good. And I know when I went through treatment and, my first appointment, getting, learning how to do the injections, I was absolutely terrified. What advice can you give to people who are about to start injections and are terrified of needles?
I think most people are. There's something very counterintuitive about putting a needle into yourself. Um, the dial-up pens, I don't know if you have this experience, are much easier to use because you're just dialing up the medication. And most people tell me, I mean, you can tell me if this is your experience or not, but most people will tell you that after they've done the first one and got over the fear of, doing something like putting a needle into yourself, it gets significantly easier. That's what I'm told. But I don't know. I suppose everybody's different. It is a really small little needle, and most people are less bothered by the needle, and find maybe the medication itself might be a bit irritating more so than the needle. But yeah, I mean it's it's scary giving yourself injections, especially if you've never done it before.
Yeah.
And I think you can have a family member give it for you if that's more comfortable. Some people really don't like that because they like the sense of control. They like to know exactly when it's going in. So some people find it helpful and some people don't. I think it's just a matter of finding what works for you. And I think that most women, by the time they get to unfortunately, by the time they get to the stage where they're having IVF, are just really, really, really willing to do almost anything to have a baby. That's my experience anyway. It's not a great thing to say, but it's the truth. I think that most people really. I had a patient the other day, she was talking about the $50 million lottery, and she's like, I'd rather have a baby than win that $50 million. It's like, it's really.
Yeah.
That's all people want, so they're willing to do almost anything.
Yeah. Yeah, that's so true. So there's a question come through here. So for IVF treatment, you mentioned that a nurse will call you a month in advance to teach you how to do the injections. But would you be given a notice in advance?
So what happens with publicly funded IVF? It's a little bit different than private. So with funded IVF, you normally have what's called an orientation with a doctor 2 months before your IVF treatment. So when you come in for your orientation appointment, that flags the nurses to call you to organise an injection teach. And you'll be told at that orientation appointment to call the following month with your day one. Let the nurses know that they can see it anyway, that you've just had your orientation appointment, and they'll organise the injection teach. So when you come, you'll be called for the orientation appointment when that time comes due, and then at the orientation appointment they'll tell you, call the nurses with your next day one, and they'll organise that injection teach. We kind of like to do it as close as possible to when the treatment starts, because it's then the injections are fresh in your mind, and also you're taking the medication home with you, so for like storage reasons as well, we want to make sure that you're not storing a whole lot of medication for a prolonged amount of time at home. If it's private and you're having private treatment, a lot of times people come in for an appointment and they're like, okay, I want to start with my next period, which they can if there's capacity to do that in the lab. Obviously, it has to be safe numbers. If that's the case, then the doctors that seeing the patient will just go down to the nurses and say, I'm going to do an orientation with them, have them sign consents. They'd like to start with the next period. Can you organise a day to do their injection teach? So the turnaround time is a bit faster, and it's a little bit different with private. And I'm also just talking about what we do at Fertility Plus. It may be slightly different at Fertility Associates and Rep Premier, I'm not sure, but I imagine it would be pretty much the same thing.
Yeah, thanks, Christine. And I hope you don't mind me throwing this out there a little bit, but you're doing some really important studies this year. Are you allowed to share a little bit about that with us?
Yeah, so I'm doing I lived in California I did reproductive medicine in California for 20 years, between Los Angeles and San Francisco. I got my master's degree there, and then when I moved to New Zealand, I started doing all these postgraduate papers, and then was accepted into the nurse practitioner training program. So I'm a nurse practitioner intern this year. It's my final year, my final 4 months, and I'll be the first fertility nurse practitioner in New Zealand if I graduate. Hopefully I graduate. But yeah, it's pretty amazing. It's actually quite common in the United States and in Europe to have nurse practitioners as clinicians doing fertility. It's a process, and it's a relatively new thing in New Zealand, but it's exciting. It will open up. Hopefully, the idea is that it will open up a lot more availability for appointments and for treatment, and that's the goal anyway, is to make it more accessible by having more providers. Yeah,
that's amazing. So good luck with that.
Thank you.
I'm sure you will be amazing. Just one thing I just wanted to touch base with you as well really quickly is, if day one starts in the afternoon, how does that work? Is it day one starts the next day, or?
So it's really the first day of your full bleed. So if you start having a little bit of spotting the night before, that's not really your true day one. And all fertility centres, if you're having IVF, when you call with your day one, they'll tell you to go and have a blood test done. And the blood test will tell us whether or not you're a true day one, because all your hormone levels will be low. They didn't used to do that, but now everybody does it. It's kind of the new standard of practice. Before we start you on medications like FSH medications, we like to get those blood test results back first. But yeah, in answer to your question, if people have some spotting the night before, that's really not day one. It's the day one is the first day of the full bleed.
Fantastic. And I know it can be a little bit hard when you ring the nurses station and get the answering phone as well. I know you guys are really, really busy all the time and got managing a full caseload as well. So I know that those phone calls do get replied to very promptly on those days as well.
Yeah, so the thing with I know it is a really frustrating system, and I think, it would be really nice to have a nice fertility app that worked well. But the thing with the phones is that there isn't actually anybody sitting at the desk next to the phone. They're doing ultrasounds and scans and embryo transfers and injection teachers. So, every hour or so they go back and check all the messages on the phones and call people back. The other thing I think that patients find really frustrating is when they're waiting for a callback for their, especially for their pregnancy test. That's a big one.
Yeah.
We do try and call the pregnancy test patients back as soon as we get the results, but we are reliant on lab tests to give us the results. And even though people are going at early in the morning, so we get the results back sooner rather than later, sometimes yesterday I was still waiting for a blood test result at 6 o'clock at night. I called them about 5 times, so sometimes it's a little bit out of our hands. But we don't really start getting results in. The first results start dribbling in usually about 1 o'clock, and they come in between like 1 and 4. So I know it's frustrating to be sitting at home waiting for results, but we're sometimes waiting for them as well. So that's why that happens, particularly if they're people are from outside of Auckland. I know some patients come to Auckland to have treatment, and they're from up north, or they're even from areas like Hamilton, or even from the South Island. And they don't necessarily use Awanui labs, so they're not really kind of integrated with our system. So that takes some chasing as well.
Yeah.
But yeah, the thing with the calling the fertility centre and not getting a live person, having to wait for somebody to call back, I can see how that's really, really frustrating. But there isn't anybody monitoring the phones for those reasons. And also, to be honest with you, it's nice if you are checking messages to be able to look up that patient and look at what their history is and look at where they are in their cycle. So when you call them back, you've got a picture of exactly what it is that they're doing. If you just pick up the phone, you'll be like, oh, let me just look you up. And, you're searching it. So you're kind of more prepared.
Yeah.
So,
thank you, Christine. Thank you so much for a very informative webinar tonight.
My pleasure.
Really appreciate your time there.
Absolutely. No, my pleasure. Thank you for spending your Tuesday with me. Yeah.
Yes. Thank you very much. And it was absolutely fantastic to have you on tonight. I learned so much myself as well. So I hope everybody else who joined us tonight got a little gold piece of nugget out of the webinar too. So make sure you follow us and keep up to date with our webinar series. Our next webinar is with Zoe Lawton, a lawyer who specialises in fertility. Zoe is going to talk to us about the legal aspects of fertility and when it's useful or required to seek legal advice. We're still confirming a date on the webinar, so keep an eye out on our website and social media. Please have a look at our library of past webinars on our website. We have a huge range of topics from some excellent presenters, including top questions to ask your doctor, managing anxiety with infertility, and genetic testing and what to expect. A big thank you to Christine for your time tonight. And thank you to our webinar sponsor, Merck. And I wish everybody a good night. Thank you for joining us.
Thank you.
Thank you.